All right, hello everybody, and welcome to another session with Pega here. Today we're going to be taking a look at this 12-lead ECG. Of course, we are going to break it down and start off with a single channel here. I don't think we'll be doing a deep dive on this one, and this is going to be probably slightly longer than just a rapid session, but let's get to it. So somebody sends you this strip. And of course, with any strip, single channel, the best you can hope for is to pull off some rates and maybe get lucky with the rhythm, right? So I'm going to start measuring things out here. I just want to take a look at the ventricular rate. So I'm going to measure from here to here just to kind of gauge what's going on here. So this is 300, 150, 175, 60. This is roughly 60 beats per minute, maybe a little bit less. Now, this over here looks a little bit quicker, faster. So I'm going to take a look at this as well over here. So this is roughly what, 300, 150, 175, 60. And whoops, let me do that again. 300, 150, 175. This would be 60. This would be over here. So 60 to 75, that's 15 beats. This is roughly 2/3 of the way there. This is maybe 70 beats per minute. So we do have a little bit of a change in rate here. Now let's take a look at the next one here. So this is 300, 150, 175, 60. This is a little bit less. Let's take a look at this one. 300, 150, 175. This would be 60. This is roughly 70. So these two over here, well, let me start writing this down. I thought this was going to be pretty straightforward, but it may not be. So let's write down some of that stuff. What was this one? This one was 60. And then these two here were 70. 70, and this was what, 300, 150, 175, 60, a little bit less. So I'm going to say this was 58. And then over here, 300, 150, 175, 60. This is again 58. So this is slightly bradycardic. And then here, what do we have? 300, 150, 175. This would be 60. This is again going back up to 70. This one over here, 300, 150, 175, 60, a little bit less. So this is 58, 300, 150, 175, 60, a little bit quicker than 60, maybe 62. So we do have a little bit of an oscillation here, and while we're at it, might as well do this one, 300, 150, 175, 60. So this is 60, and what we're getting here for the rates is kind of picks up and it drops down, and then it picks up and it drops down. So are we looking at PACs? Maybe, and depending on where you work at, this might be classified as a PAC. Sorry, let me just take a look at this here again. 300, 150, 175. 60, and this would be 300, 150, 175. Pull it over here. That's, yeah, okay. I'm content with that. What else do we have here? Let's take a look at the P waves. If we can, if we can see any. I'm not really seeing any P waves, not clear in any way. Right there, that looks like a P wave. And if you do have a magnifying glass, or if you don't have a magnifying glass, take a snapshot with your phone and zoom in. It really helps out sometimes. I mean, I certainly do. So here we have, what looks to be a P wave. Here's another one probably. This is probably again a P wave. I'm just kind of going through it. This right here would be a P wave. So the P waves, the PR interval is staying pretty consistent, I would say. We don't have a first degree heart block. The P to P marches out. The sinoatrial node is driving this rhythm. What we have here is baseline artifact. Okay, so here everything is getting shifted, and this is just baseline artifact. So we have what I would say is a consistent PR interval. A baseline artifact, and we have a heart rate that seems to be going up, coming back down. I would really like to see these changes in heart rate to be a little more gradual. So instead of going from 60 to 70, maybe this would be better if this was 65, and then over here you had a 65 as it comes back down to 60. But this is sinus arrhythmia. This is sinus arrhythmia. Okay, it's probably due to breathing, but I'm not 100% here. These changes are just a little too sharp. Could be something else going on. Let's take a look and see what we can get when we switch over to 12 leads. Okay, so now we're cooking. Okay, so down here we were looking at lead 2, right? Okay, so here we can see the P wave a little more clearly. Right here, see that? There's a P wave, there's a P wave, there's a P wave. The P waves are present here, and the PR interval seems to be consistent. So yes, the sinoatrial node is driving this rhythm. The P waves are upright in inferior leads. Okay, it's inverted here, but AVL is inverted overall, and so is AVR. Okay, now that's a red flag. AVR is inverted. You know what's going on here? Oh, look at lead 1. Look at lead 1. Lead 1, we have an inverted P wave. We have an inverted QRS. Okay, now this. Normally, if you had, a large S wave in lead 1, you'd be looking at a fascicle block. But here, everything is inverted. See this? Everything's inverted. So we're getting a completely opposite depolarization than what we'd expect. And while I'm zoomed in down here, I'm kind of taking a look at this. We seem to be getting a little step off the baseline here, sort of like ST elevation, but there is an issue here that's present. So here, what we have is we have lead inversion. So we have an inverted AVR, we have an inverted lead 1, we have an inverted AVL, and everything else seems to be okay. So a little flashback to, let's see here, leads. So when we're talking about leads, you're placing electrodes onto a patient's body, right? You're going to put a positive electrode on the patient's left shoulder, and there's going to be a negative electrode on the patient's right shoulder. And when you're grabbing these electrodes, this is going to say right arm, this is going to say left arm. But the important thing is this is positive, this is negative. Okay? And then what we have here is an inversion. Or better said, what you would expect as the lead 1 is moving from the patient's right side to the patient's left side, you would expect to see a movement towards that positive electrode, right? So you would see a positive deflection. Here we're seeing an instantaneously negative one. In fact, if you had to classify this, this would be a major Q wave followed by a small S wave, which is not impossible, but it is extremely strange for lead 1. So what do we have here? When the electrodes were being placed on, the right arm and left arm probably got reversed. So see down here, this is what you would expect. This was inverted. So you get the mirror image. If you had a mirror down here, right, the reflection of that would look like something like that, right? Which is exactly what we have going on over here. So this is a lead inversion. However, as a consequence, we have an inversion in AVR, and we also have an inversion in AVL, which is to be expected. Now, let me reiterate that. So when you're placing on these electrodes, right, here's your left arm, here's your right arm, you're placing them on the patient. Now, if you were to reverse this, you would get exactly opposite results. However, you will also affect AVL, and you will affect AVR. So AVL and AVR, these are augmented leads, and they are calculated. These are a mathematical calculation that stems from the Wilson central terminus, or essentially the center of the heart. Not quite, but close enough. So what happens here is you will also get inversions in those leads. So what we have here, sorry, I made a mess of this. So what we have here is a lead inversion in lead 1 is inverted. As a consequence, we're having inversions in AVR and AVL. So the first thing I would do here is fix this. That's going to give you a more accurate picture of lead 1. That's going to give you a more accurate picture of AVR, and that's going to give you an accurate picture of AVL. This was sent to me over here, and with no demographic information of what's going on. It was just an ECG somebody sent over. So we do have baseline artifact. It looks like we do have sinus arrhythmia. And then another thing that really kind of stood out to me, anytime I get ST elevation in inferior leads, and this paper has been warped. You can kind of see these lines here. This was probably somebody just took a snapshot of something that was going on. But this paper is a little warped. Is this real ST elevation? I'm not sure. I'm not sure. Okay. Down here also, it looks like we might be looking at, half a box to a full small box of ST elevation. Is this because the whatever happened with this lead reversal is affecting this down here? I don't know. So I would wait to get the lead inversion. Lead inversion is not something to be taken lightly, even though it's like, whatever, you inverted the leads. All right, reverse them, take a snapshot if it's not a big deal. The reason I bring this up is anytime you have any sort of ST elevation in inferior leads, you want to take a much closer look at everything that's going on. So inferior leads, if you take a look at guidelines, you're looking for 1 box increase, or you'll be looking at, this 1 small box worth of an increase, and, red flag will go off. However, I am, through experience, absolutely any ST elevation in inferior leads, you want to take a closer look at the right side of the heart. So maybe do some right-sided chest leads. Posterior leads are also not a bad thing to do if you're getting ST elevation in inferior leads. And one of these videos we'll do on ST elevation, and I'll, chances are it'll be an inferior one, and I'll show you what I mean by that. But for right now, what we have here is we have sinus arrhythmia. We do have sinus arrhythmia, right? It's a little bradycardic, little normal. We do have lead 1 is inverted. And, well, I didn't really take a look at this over here, did I? looking at this over here. Sorry, I'm just, anytime I get these spiky QRSs, I start running RVH, LVH criteria through my head, and I'm not really seeing anything here that sets off a flag for hypertrophy. So we're going to leave that alone. We do have early R wave progression. So there's a switch from predominantly negative to a predominantly positive that's happening early. So something is causing that. Not sure what in this case. And what else am I missing on here? Oh yeah, let's take a look at this QT. So I'm just curious here. Right, this is our R to R roughly speaking, and this is 1, 2, 3, 4, roughly 5. So 1, 2.5. That's our midpoint. Here's our T wave. T wave ends well before the midpoint, so the QT is okay in this case. Okay, I guess that's it for this one. Just a little bit of sinus arrhythmia. We do have an inversion in lead 1, so the wires got reversed. That needs to be fixed. And then, if you are the one that's taking care of a patient with something like this, you definitely want to keep an eye on absolutely any ST elevation in inferior leads. That's it. Pretty short one this time. We'll see you guys on the next one. Thank you. See you next time.